Good morning, everyone. My name is Fran Ayala Somayajala. I am the CEO of RTL Innovations and the president of REACH, a global social impact organization. It's my honor to be here with you today with this distinguished panel. We have an amazing lineup of discussion where we're going to look at health equity and cardiovascular disease. Before we get started, I'd like to allow for each of our panelists to have the opportunity to introduce themselves. Dr. Mikos?
Hi, I'm Erin Mikos. I'm a preventive cardiologist at Johns Hopkins University, where I also have the pleasure of working with Dr. Seth Martin, who's on the panel. I focus on preventive cardiology and women's health. And I'm on this panel because I'm interested in improving enrollment of women and other diverse populations in clinical trials. And I'm collaborating with Dr. Martin on his AHA Strategic Focus Research Network on mobile health technologies and innovations. I'm very pleased to be on this panel today.
Excellent. We're pleased to have you. Dr. Martin?
Thank you, Fran. Good morning, or whatever time of day it is to everybody who's joining. Thank you for joining. It's been a pleasure to get to know you, Fran, over the last few years. I'm looking forward to this conversation. It's been great to collaborate with Dr. Mikos, as she mentioned. So I am a preventive cardiologist as well at Johns Hopkins, and I have the pleasure of directing our MTech Center, which stands for Mobile Technologies to Achieve Equity in Cardiovascular Health. It's part of the AHA's Health Tech and Innovation Network. So looking forward to the conversation and looking forward to sharing some of the work we're doing in our SFRN network. Thank you.
Thank you so much. And Dr. Srivati?
Hi, good morning. I'm hailing in from the West Coast, so forgive me if I'm a little bit slower this morning. I'm a general cardiologist who was trained at Stanford, but I currently work at Google, where I'm a senior clinical lead. And I spent a lot of my time thinking about health equity from a product lens. How do we make our products more accessible, understandable, and useful for all communities, and particularly those who have received less access and inclusion historically. I also practice at a safety net facility about 10 minutes away from Google, taking care of predominantly Medicaid patients. So I get to think about kind of the applicability and the translation of the skills that we're doing at Google in real practice.
Excellent. Thank you so much for that. And Dr. Shah, Neil Shah?
Hi, good morning, Fran. My name is Dr. Neil Shah. I'm an internal medicine physician at New York Medical College in Valhalla. I also work with a lot of underprivileged population in the Westchester area. And along with Seth, I'm also part of AHA's Health Equity and Health Tech Innovation panel as well.
I love it. Thank you so much. Thank you, everyone, for your introduction. To get us kicked off, I really want to sort of begin with a level setting on health equity, right? Because let's be honest, there are lots of definitions that float around. And the research of REACH has actually revealed that amongst providers and researchers that, in fact, there's a misdefinition, an inaccurate definition of the term health equity, as the emphasis being on equity and oftentimes being interexchanged with the word equality. And that's not essentially what we're talking about when we talk about health equity, right? That basically equity is about making sure that people have access to what they need in order to achieve health and wellness, as opposed to simply just being provided with the same tool as everyone else, which may or may not be useful. I'm curious to know, in all of your practices, as well as the research that you conduct, if you could attest to this a little bit and explain to those who are participating today some of the distinction and why it's important. So perhaps to get us kicked off, we'll start with you, Dr. Shah, if you don't mind.
Of course. So, I mean, I think the biggest thing to discuss, and as you kind of mentioned, Fran, is the equity versus equality, is just making sure that everybody has the ability to get what they need, be that in a rural area or be that in an urban area, and being able to provide the quality care that we know that we are able to when we have the resources available.
I think that's a very valid point. And how do you sometimes see this show up? Dr. Srivati, perhaps you might want to make a comment in terms of the populations that you're currently serving and the practice that you have here in the Bay Area.
Yeah, I think when cardiology providers are in a safety net or in other communities where there's a limited access to pay or social determinants of health are really top of mind, it's hard to kind of isolate one population from the other and say they need this versus that. I think we keep, at Fair Oaks Health Center, health literacy, ability to pay top of mind for all patients, and we make it explicitly part of our notes and how we are thinking about highlighting even, social or housing limitations as a diagnosis code to kind of keep things top of mind across providers. That we have to ask those questions and make it explicit to make sure that we're not assuming that one population or one patient has it a particular way when in fact they do not. I would say from a product lens, when we're thinking about health equity, it's really spending and focusing time on those priority populations who need the research and the attention the most. So it's being explicit again and doing the research and focusing on, for example, trans, LGBTQ, Black, Latinx populations. And again, making it explicit, writing it out in the documents and making those partnerships a priority.
All very, very valid points. I've had the good fortune, as Seth has mentioned, to know him for quite a while, Dr. Martin, and I'm just kind of really excited and impressed by the work that you do within your clinic. And I know one of the areas of emphasis is on, post-operative, post-cardiac, post-MI patients. And I would presume that in that you see a variety of individuals, right, a diverse population, and some of the technology that you're looking to introduce may or may not work for some individuals. Can you describe for us in the context of what we're talking about, how that shows up in terms of the patients that you're seeing and how you're responding with the use of digital technology?
Yeah, absolutely. Thank you, Fran, for the invitation to join in, and to try to build on some of what Jacqueline and Neil were saying. We, in Baltimore, we have a very diverse population, and just a matter of miles across our city, you can see differences of decades in people's lifespan and their coronary heart disease outcomes. And so as we've looked to solutions and we've collaborated with amazing colleagues in our Center for Health Equity, Yvonne Commodore-Mensah and Lisa Cooper, we've really looked at digital technology as a starting point. And it's not just taking tech and then bringing it in and saying, here's the solution. It's really using tech as a platform to meet the needs of the end users. And we see really tremendous opportunity for tailoring. I think that picks up on kind of what you were saying at the beginning, Fran, around equity. We're thinking about equity as everyone having the opportunity to achieve their optimal health, their optimal cardiovascular health. And we need tailored solutions. It's not a one size fits all approach. We need tailored solutions, and digital smartphone wearable technology really provides that platform to build that tailored solution. So how do we build the solution? It's not that we get a bunch of cardiologists sitting in a room together and find some engineers who are willing to help us. We need to bring the patients, their families, their caregivers into the process. Our amazing fellow who Aaron and I have the pleasure of working with, Nino Isakadze, is leading our human-centered design sessions in collaboration with Nancy Malello and the Center for Health Equity. And that's really the approach that we take, the equity lens to the product development. It's a co-creation, co-development with our patients so that we ultimately are meeting their end needs, because we can't think of all the different needs ahead of time. We really need to bring them into the process and figure out, okay, here's one need, here's another need, here's another, and then prioritize the product development based on those needs. So that's some of what we're doing. Maybe as the conversation goes on, I can talk a little bit more about the hardware side and sort of the loaner program we've developed in terms of, because access to even if we build a wonderful platform, a wonderful app, the access to the technology and then the coaching around that are still critical issues. So maybe we can touch on those later in the conversation, but those are some kind of initial thoughts on how we start to build the solutions.
I love it. And I really would I know it is early because I think I started my day at 4:30. I, like Dr. Srivathy, am here on the West Coast in San Diego, but somehow I still have this energy this morning because I think of this awesome conversation. So I do encourage all the panelists to jump in. I mean, Dr. Mikos, the moment that Dr. Sev started to refer to how he is using this technology in the clinics and the way it shows up for some patients and not for others, made me instantly want to gravitate towards you. And I'm curious about your thoughts, particularly as you look at it from a gender perspective as well, right? Do we see the same kind of response and or uptick? Is there some perhaps differences between the way that genders embrace this technology?
So great. So again, I'm thrilled to be on this panel, and I'll get back to your first question, which is just defining, of course, health equity. And as everyone said, this is really so that each person can attain their his or her full health potential, and no one's left behind. And so this really involves removing all these obstacles related to poverty or discrimination, powerlessness or lack of access. Improving things, housing and quality education and fair pay and things about the environment. And we're talking about inclusion for research, and it's beyond just gender and race, ethnicity. It's also LGBTQ status. It's about geography, rural versus urban. There's so much disparity across the broadly. And I do think that technology can be a way to bridge some of these gaps. So what we talked about is, often you have to provide the technology. So as Dr. Martin talks about, he'll talk about his loaner program for his Apple iPhone that they use for intervention. I was really impressed with the hypertension late breaking clinical trial session. I don't know if you heard Dr. Blood's presentation, but he talked about this digital health management program that they were able to launch to 10,000 individuals. There was a blood pressure arm and a lipid lowering arm. And this was really with some patient navigators. These were non-licensed individuals, along with pharmacists, and algorithm driven, this remote management program. And they offered the technology, free of charge. They had these digitally linked blood pressure cuffs that they provided. And so using this pharmacist-driven, algorithm-driven protocol, they were able in the intervention arm to reduce blood pressure, systolic blood pressure by 10 millimeters of mercury. That's really huge. Diastolic blood pressure by 6 millimeters of mercury. And they had similar dramatic improvement in lipids. So this shows that with less in-person visits, less clinician time, and using technology, it can work. But the challenge was in that study, half the patients didn't stay in the maintenance program. And so, how can we keep people engaged long-term in a digital longitudinal plan? And so I think that's really important. But one thing I'll point out, because you got back to gender, is in Dr. Blood's study, 55% were women. So more than half of the were in this population were women. So another big example of a study that was able to enroll a lot of women was yesterday. We also had a session on virtual longitudinal cohort studies. And we heard about the Apple Women's Health Study that Dr. Malalinga presented. And so basically, they were able to enroll 10,000 women into this program. And this did require an Apple iPhone. And so you would think that would be a huge barrier, but you'd be surprised actually who has access to technology. And they were able to enroll these 10,000 women, individuals that were really quite diverse in race and ethnicity and education and economic status, despite the fact that you needed an Apple iPhone to enroll. And this really shows that you can enroll huge numbers of women in clinical trials and to study them, particularly if you ask about questions that resonate with them. So what the Apple Women's Health Study had questions around menstruation and health, menstrual cycles, health and behaviors. And this is, kind of a taboo subject. Nobody wants to study these women health issues like menstruation. But if you actually study issues that resonate with your end user, that the population care about, you can help recruit with individuals when you study topics that are meaningful to them. So in some, I do think that women want to participate in research. I think technology can help bridge the gap, but it's asking questions that resonate with them.
Yeah, that's certainly a very valid point, and that transcends. You had kind of alluded to geographies as well, and Dr. Shaw, I know that's been an area or a point of interest for you in the telehealth environment. Talk just from the perspective of rural health and rural communities.
Yeah, definitely. And Aaron, that I wanted to actually ask you a question, kind of follow up to what you were saying as well, is, one of the challenges we do see is in our rural communities. If we give them these devices, how do we ensure that we have good connectivity to them? Broadband internet may not necessarily reach to all these individuals. Yes, we give them a blood pressure cuff, the iPhone, and et cetera, whatever they need. How do we get that information back? I mean, even I live in a relatively urban area, but we still have dead zones. We had a patient who we had an event monitor put in, which we couldn't even get the data for because they had no connectivity where they were living. So even in a relatively urban area, we still have these challenges. So how do we scale this to even reach the rural communities throughout the United States?
That's a very valid question. I know that there are a lot of hybrid models that have been introduced, right, that take advantage of both asynchronous and synchronous optimization to make sure that data is available. But there's still a lot of learnings. And as Dr. Martin had alluded to, in part, it's about the way that we design. And it's not just the design of the technology, but also the design of the programs themselves. So I think it'll be great for us to talk a little bit about that. And before we jump into it, I would like to back up though, and I have, would like to ask the question, do we really feel as though we are improving the quality of care through these technologies, through digital health? Does anyone want to perhaps jump in and give your initial thoughts on that?
Yeah, I can kick us off there, Fran. I think that we're still in the very early phase of improving care, but we're already seeing improvements. I think Dr. Shabati published a beautiful article about just during the pandemic in terms of just voice only care. So I'd love to sort of invite more about that. I can just briefly share about our CORI program and what we're seeing through our initial MyCore trial. This was led by Francoise Marvel, who's been just an amazing driver of our CORI program over the last 6 years, and along with Aaron Spalding from the nursing school. So we delivered the type of technology that I was referring to earlier that we build in partnership with patients at the time that they had a heart attack, at that moment that really matters when they're wondering what's next. And we delivered this smartphone app plus the wearable plus the blood pressure monitor. And in that, through that approach, which was really a comprehensive approach to guide them through all the steps of guideline-based prevention, we saw low readmission rates over 30 days after discharge from the heart attack. So we saw, compared to the historical 18 to 20%, we saw a readmission rate that was cut in half. We saw very high levels of patient activation. And we think that that's really explaining the results, that patients are becoming activated, confident in knowing what they need to do. And just to give a very concrete example of what that activation looks like, one of our patients, and we published her story in BMJ case reports, and she provides her patient's perspective here. But Dr. Marvel enrolled her into the trial, and Dr. Marvel then was busy and had to go do something. So this patient, Tammy, really just got herself kind of onboarded onto the app. And by the way, she was using, before the trial, like a flip phone, so that the smartphone technology, all of it was quite new to her. And she then said that she binge watched the educational videos. And the next morning she was asking more questions of the team on rounds. She started tracking her steps around the nursing station on her wearable. And as she went home, she really overhauled her risk factor profile. She continued to use the technology 2 years later. She not only improved her cardiovascular health and stayed out of the hospital, but she got promoted to a manager position at Walmart. And so really, in her case, she became highly activated and is an example of how we can reach someone who many may have kind of passed that off to say, well, she's not really a tech literate person who's going to connect with technology. It's not going to work. It definitely worked for her. And she's an example of that really activation and how we need to meet people where they are, and not assume that there's certain people where technology is going to work or not work. We just need to give people a chance.
I love that example. And I've definitely seen that in my own clinic experiences. Again, like being explicit and making sure we're asking everyone those same questions about motivation, health literacy, how their health relates to their occupation and other social determinants of health. So it's very powerful and it resonates with me as well. I did want to go back to referencing the perspective I had written recently on the value of audio-only telehealth, because it's something that was really foundational for me in 2020 with my patients. I was taking care of them primarily with the telephone. And going back to, does all technology improve quality? I think I realized during that year that the things I'd taken for granted, the telephone, were actually a core source of technology that I could use to access my patients. To, I hate the term, it's overused, but meet people where they were. In that case, it was often at home, or for many of my patients, they were essential workers, and meeting them when they had an extra 10, 15 minutes between their shifts. And I think CMS has also realized the value of some of our kind of less shiny objects when it comes to digital health. The fact that they've finalized in the 2022 physician fee schedule that they'll be paying for covering audio-only telehealth for behavioral health, for mental health, is really, I think, a important step. And I hope it reverberates into other fields like cardiology and neurology and the like, where you can, not always, not for all patients, but for some select patients, particularly for follow-ups, you can drive effective care using simple technologies like the phone.
It's a brilliant example of where we do get caught up sometimes, right? Because it's always the chase, even with the latest and greatest. 6 months later, you got to get this new gadget. So how do we do that? Is that really realistic in the context of our health? Is an excellent point. Let's expand upon this a little bit more. Let's dive into the context of the research, right? Because that's an area where we also see oftentimes a lack of parity, inclusion, and representation. And presumably there may be some opportunities where technology may be able to be utilized. And so curious to know your thoughts in relation to how digital technology can be used to help enroll patients into trials and help us to address this sort of chasm that exists in terms of representation and panel diversification when it comes to research. Perhaps Dr. Mikos, would you like to first kick us off?
Yeah, so I do think that tech and digital tools can help boost our female representation in clinical trials. The traditional clinical trials that we certainly had to do before the COVID era, participants would have to come into the trial site and come in for all the study visits, and they may not even be referred in the first place because women often don't get referred to specialists or get referred to areas where we recruit from trials. And so we have a huge problem in cardiovascular clinical trials of the underrepresentation of women. So women patients make up about 25 to 35% of participants generally in cardiovascular trials. And, but if you actually benchmark it to the disease prevalence in the population, because cardiovascular disease is a disease of women, women are underrepresented by about half relevant to their disease burden. So they may be less likely to perhaps have acute coronary syndromes at a given age than men. But when you look at the population numbers, they're still underrepresented. So digital technology and really moving to decentralized trials, I think, can really bolster enrollment of women. And we've now been seeing this in the COVID era with the vaccine trials. And I mentioned trials like Dr. Blood's trial that was all digital, these virtual trials. So by having these digital tools, follow-up is a lot more flexible. You can do it online. Often if there is lab work, patients going to their own lab near their home versus having to come into the central lab at the study site, following up through their PCP online, makes it a lot more flexible so that individuals who, are caretakers to other small children or older parents, or, have a job. I mean, it's really hard to, take a time off work and drive into the city, because most of these trials used to be done in academic centers, in big cities, and it's, hard to get in. So these digital trials can help with flexibility, avoiding hitting cost. While trials often supplied the drug or the device, there would be costs related to transportation, time off work. And so the digital trials overcome that. And so, if there is a study drug, mailing it out to the participants at home. One thing that I think is really, really important, and Seth and Nino has been working on this about human-centered design, is involve women patients in the design. You want to have a trial that's, one, resonates to issues that they care about, and two, that they often can identify barriers and even things of how we educate about trials. Women patients tend to be a little bit more risk adverse. They tend to overestimate risk related to a trial and underestimate benefits. But there's actually enormous benefits with just participating in a trial. Even if you don't know if a drug or device is going to be effective or not, by being in a trial, you have more contact with the healthcare system and you have more access to gold standard of care. And so there's a lot of health benefits with just being in a trial and having someone follow you and check in on you. And so communicating about trials and how we educate and do the enrollment. And so with these virtual trials, we've moved a lot with e-consent, and we can do consent forms in different languages. And I think that creates a lot of opportunities. One thing I'm really passionate about is also diversifying the study team and investigators. I think that it can enroll enrollment again when the study team is more reflective of the underlying population. So having more women in leadership. But yeah, this pragmatic through online apps avoids a lot of these burdens. And then if there is technology, bringing the digital, the tech to the patients. So I can talk a little bit more about sort of the ins and outs of decentralized trials, but I actually think that, there's always some concern about whether we can talk more about this, about the digital health divide, whether these digital trials will worsen or disparities or actually promote inclusivity. And although things are not perfect, I do think that data can bring inclusivity, and that we are able to reach out to a broader range of individuals by gender, race, ethnicity, geography, that when you get beyond the bricks and mortar of having to come into a fixed clinic site, an actual site, that by doing things in the virtual space, you can enroll a lot more broader population, which is important for a drug or a device to show that it has safety and efficacy in a broader spectrum of the population. This makes the results of any trial more generalizable to the patients we see every day in clinical practice.
Yeah, very valid points. I would see, though, how it could be a challenge, right? And that trust becomes a very huge issue. And I see Dr. Shaw nodding his head. I'd love for you to perhaps step in on this one and talk a little bit about the trust factor that's so valuable, because, some trials might seem a little bit more of a lower risk than others, particularly when we're talking about pharmacological research, that can be deemed as a little bit higher risk, and a lot of trust has to go to that for patients. Tell us what your thoughts are and your experience.
I think one of the kind of underlying theme of what everybody's kind of alluding to is the more prevalence of telehealth that has kind of come about over the last 18, 24 months with the pandemic. And I think that actually now essentially it forced us to go into a more, decentralized and sort of telehealth sort of strategy. And I think what's great about that is oftentimes patients are a little bit apprehensive at first to enroll in a trial or something like that, and they want to think about it. And now we can have shorter follow-ups, a phone call or even just a telehealth visit where, we'd be like, hey, are you still interested in joining this? And that way we can help improve recruitment and help answer questions and things like that, which previously we may not have been able to do. And more towards Erin's point, when you are enrolled in a clinical trial, you have a lot more healthcare exposure, which is actually better, which has shown better outcomes. Maybe a little bit of a Hawthorne effect there, but I do think that the outcomes of patients do are improved based on these.
I can jump in here when we're talking about informed consent. I think from a tech point of view, when we've had to do some of our usability testing and we're doing it completely remotely, digitally, I've struggled with thinking about how do we effectively and clearly consent our users. I think all of us, when we get a new update on our phone, we're very easy to just kind of scroll to the bottom real fast and click, yes, I accept. And it's always been in the back of my mind when we do these internal usability studies. Are we getting people to do that scroll effect? Or are they reading line by line? Because when it comes to health, when in person, when we're doing these trials, we usually have someone there with us, going through it line by line, being there to ask questions. And sometimes that functionality is available for digital health trials. It might be done live, virtual with a recruiter, but if they're doing it completely remotely, there's always this risk that people are signing up for things or for use of their data that they may not be aware of. And I'm just curious from the group here, who's doing a lot of the clinical peer-reviewed work in this space, like how do we really, and access is like, the funnel here is really core to our delivering our mission of health equity, and it begins with informed consent.
Great question. Anyone want to jump in on that one, Dr. Martin?
Yeah, thanks, Fran. Yeah, I could add a little bit of our experience. So I mentioned our MyCore trial previously. I mean, first of all, I agree with Dr. Shribati. The informed consent process is critical, and frankly, I still think there's a lot of room for improvement throughout the clinical trial ecosystem. We use Research Kit. So the way it's presented is in an app. You get kind of like a one-liner for like each section of the consent, kind of a one-liner, like the big picture point, and then you can click to get more details if you want to read more. I think there is a lot of heterogeneity in just in general as people enter trials, how much they want, if they just want to sort of jump to saying yes, or they want to know every line by line, or they want to have sort of information in between. So in addition to that app, after you go through it, there also was, we had a very clear disclaimer kind of note at the end, like making it clear that this research participation doesn't replace your clinical team in any way, and really reinforce that. I think it's important then still to have the opportunity for questions. So if you're consenting remotely, I think there needs to be a number you can call or a way you can reach out to ask questions and engage in that discussion. But in general, I think consent, whether it's research or the consents for procedures in hospitals, often it's a process that still leaves a lot to be desired in terms of, are we really helping folks understand what they're signing up for? And it gets back to your point too, Fran, about trust. And so I think as we think through the process of consent, of recruitment of patients to trials, it's very important, again, to go back to our community, to our patients. Our colleagues at Johns Hopkins and the Center for Health Equity have a community advisory board, and they learn a lot from that board in terms of how they plan their recruitment strategies. And then, improve when you're not hitting your recruitment goals, you often answers of how you can do better are there going to the people. So those are just some comments to add. I'll kind of throw it back to you, Fran, and see what else the rest of the group has.
Yeah, I think it's really challenging. I mean, to understand the elements of trust that could facilitate inclusion when using digital platforms. And I think this is why often trials do need a hybrid component. So I think participants are more likely to sign up for a trial if it comes recommended by a person they trust. It may be their clinician, their primary care doctor, or some other community member, or, a person who, kind of vouches for this trial. And so I think that, when you get contacted sort of remotely, suspicious, how are they collecting my data? What are they going to use my data for? I mean, rightfully so, especially in certain communities and persons of color, because there's enormous mistrust, and rightfully so. And so how do we overcome that? And that's why I think that, we still need some kind of hybrid approaches with follow-up and interaction by, trusted investigators who've come recommended from the patient's own, personal, primary care providers. And so, this is still a work in progress, but I think, having that in-person contact with the virtual contact, I think, you can't have entirely a virtual enrollment by remote people that you get contacted by that you have no idea who they are or what they want and why they're collecting your data. So it really needs to at least be funneled through a trusted source.
And to piggyback a little bit off of what you're saying, Erin, in research, we're a lot more rigorous in how we're recruiting and what we're exactly doing because of the things that have happened to individuals of color and the experimentations that have happened throughout history. So, we have to be very upfront and making sure that we're doing so. And when we do this recruiting process, I think that's very important.
Yeah, that's a very valid point. In fact, one of the questions slash comments that was in the chat was around why do we go through all of this rigorous effort? But I guess the easy way to answer that is, ask yourself, would you like to be enrolled in a trial and not made aware of it? And if you think back to, my background being epidemiology, right, I think of some of our classic cases like in Brooklyn Hospital, where babies were exposed to high levels of oxygen and as a result had blindness, right? The outcome was blindness, and their parents were not informed, and that had nothing to do with color or income. It had to do with the processes that were taken around deciding how children could be utilized or enrolled in trials and research without the consent of their parents. So that would be the first thing I think, and I would love to see more questions coming in from the chat as we kind of move into this second half of a segment of this session. Let's go there in terms of design, because I think you guys have brought it up a couple of times, and I think it was important to sort of lay the groundwork for what we're talking about, right? We've talked about opportunities, we've talked about some of the challenges, some of the realities of what's being faced, and why it is important to have standards, protocols, and procedures, right, around the work that we're doing, whether it's from a care delivery or from a research perspective. But what does this all mean, or how does it show up in the context of the design of programs and the design of technology? And to kick us off, I hope, Dr. Shervati, you'll be willing to give us some examples from those you've seen doing some of the research and how they've begun that, how they've began to structure the programs that they've conducted.
Yeah, we've gotten some great insight into kind of on the ground research, particularly as with my working with Fitbit in the last year or so, where there is this Fitbit HealthEquity Research Initiative, where we recently awarded 6 researchers, and I would like to emphasize they're early in their career, which I think is really important and foundational to broadening the pipeline early on. And giving them both Fitbit devices and services to support their research projects. And again, being clear that we're focusing on particular populations, priority populations that we really think deserve more exposure and more opportunity to be involved in digital health. And there's a couple researchers. There's one, Dr. Deach, who is an assistant professor of psychology at Oregon State University, and she's using Fitbits to help understand how gender-affirming hormone therapy impacts sleep health in transgender youth. So it's actually for young investigators like Dr. Deach, she's identifying an area where there really is not that much help in terms of design. Like, this is a very kind of burgeoning field, understanding and using digital health technologies to understand kind of the impact of hormone therapy on physiology, such as sleep. And I think that the key is starting early and having that type of dynamic conversation with our with these researchers and giving them the opportunity to kind of begin the field, so to speak. So I think in these areas where there is less experience, in comparison to perhaps like RCTs for cardiovascular therapies, we are kind of in this new territory where we have to I think give researchers the opportunity to ask those difficult questions, and sometimes gifts, unrestricted gifts like this, are really kind of the way to touchstone someone's career.
That's fantastic. And I guess really the opportunity extends out to communities as well, right? Or populations or subpopulations. If we think about some of, particularly, from an IT perspective, sort of creating this co-designed solutions, that there's opportunity to do that equally in health. And places where we've seen being successful, like in areas like HIV/AIDS, for example, where we had co-chairs that had both not only individuals from departments of health, but also co-chairs who represented the communities directly, working together to design programs that the outcomes were much more effective. Do you see the same opportunities within cardiovascular disease management? I see some heads nodding. Anyone want to jump in? Yeah.
Well, I just wanted to take a step back again and just make sure the audience is all on the same page about decentralized trials, because I think more and more trials, including in the cardiovascular space, will be like this. So again, the traditional approach is where you bring the data to the researchers, and it really discourages shared research. Each trial, each center, each investigator is within an academic silo, and it's very sort of centralized. Or a cloud-centric approach, often through a company that you're partnering with that's, outside of a single institution. So this approach actually brings the researchers to the data, and it helps facilitate collaboration. There can be a single centralized security control. It can be accessible to all researchers. There can be decreased costs of storage because you're really leveraging shared tools across a larger ecosystem. And so I really think decentralized trials are critical and really needed to improve population health. And so decentralized trials, this term can mean a lot of different things. So it includes digital tools, such as we've been talking about, like electronic consents. It can be the use of home health providers. It can be direct-to-patient drug distributions. It can be these remote monitoring that we're talking about with all of these, Fitbit and blood pressure and heart rate apps, other diagnostics. It can just be the use of participants using their own local labs, their own local imaging, and not coming to a central place. But really, again, it's getting beyond the bricks and mortars, and participants are engaging in some form online. And so I think that this really can leverage a lot of opportunities to use novel technologies and processes to create options for participation outside conventional clinical trials and improve access and improve convenience. And so really, I think the old way we were doing trials is slipping away, and COVID really changed the pace and speed of how we had to do research. And digital trials like this, virtual trials, has really changed the pace about we can enroll patients far more rapidly. You can enroll, 10,000 patients. We saw this with the Apple Watch study. We can rapidly enroll patients. And, using a pragmatic design, leveraging EHR systems for cardiovascular outcomes, doing the traditional way where you adjudicate each outcome by a committee, that may be the best way, but that takes so much time and delays things. So if you use outcomes that are captured through ICD-10 codes through HR, it's very pragmatic. And we have a number of examples of this. So first, we had the Adaptable Trial with Aspirin, comparing high dose versus low dose aspirin. This was done led by investigators at Duke. And so that was a pragmatic trial. And now ongoing is the Preventable Trial, and testing aspirin for primary prevention in adults over the age of 70. Again, using they're providing study drug, and there is some in-person, in-point contact points, but a lot of participants are getting labs locally, and but again, collecting outcomes through a pragmatic EHR approach. And so I think that cardiovascular clinical trials are being rightfully revolutionized as we're going more and more through these decentralized digital approaches for both data acquisition and outcome assessment.
I think that's a really valid point, Dr. Mikos. And the truth of it is, it was actually prior to COVID, right? So we've been engaging in decentralized trials now for about 5 to 7 years. it's been slow to uptake, but certainly being in a period of time where we wanted to continue our productivity and discoveries, we ended up leveraging it a lot more and seeing the benefits. And bringing that, of course, then back to its value to patients is where we really want to see in terms of context of health equity. How do you see that, and this is for all of the panel, please anyone jump in on this question. How do you then see the opportunity to communicate this new way or new approach to patients in a manner that will help to encourage their participation in studies? Do you see any value add there? Do you think that they really care? Does it make a difference? What are your thoughts?
I think overall patients are relatively excited / eager to be part of certain clinical trials, especially when it comes with devices. Pharmacologically speaking, oftentimes patients have a little bit of reluctance, but when it comes with medical device research, patients are relatively excited because they saw with the Apple Watch, how much more information that you can get and bring that back to your provider. So I think that the enthusiasm and recruitment of individuals actually is more beneficial with this sort of decentralized model and with healthcare technology.
Yeah, I agree with Neil. And I think that patients are expecting in general, like in 2021, almost 2022, that we are going digital. Like, if we're not, I think it would be a bit funny, but just to kind of, circle back to some of the sort of design thinking and bringing patients into the process. And also just to kind of tie in with, there's been quite a bit of activity in the chat around Henrietta Lacks, which is an example of sort of what not to do in sort of the older era when we weren't really approaching things from this lens. So that is an example from Baltimore, actually, Henrietta Lacks, where her cells were used without her consent after her life. They've led to tremendous advances in research, but they were used without consent. So really, it gets back to the way that we approach patients and bring them into the process of designing trials, decentralized trials, as Dr. Mikos is sharing. But ultimately, it's about so many aspects of the trials, including the outcome. I mean, the value to patients is ultimately, what is the outcome that we're trying to achieve? And often in cardiovascular research, we gravitate towards MACE outcomes, major adverse cardiac events, but there's a lot of other quality of life outcomes and other things that are important to our patients. So I think it again gets back to bringing patients into the process of designing the intervention as well as the test of that intervention. I think that's the direction we're going, and we'll see more and more of that in the years ahead.
So how does that actually show up in the context of design? What does that look like? Does that look like a design team or research design team actually soliciting the participation of, say, a community-based organization? What have you all seen, or Dr. Martin, what have you seen in terms of how this actually shows up in the practice or in the actual design of programs?
Right. Yeah, I'll try to make some brief comments. I'm sure the other panelists have comments that as well. So I guess one thing's the design of the intervention. And for our team, that started with Francoise Marble interviewing patients at the bedside when they're in the hospital with a heart attack. And then we've gone to an even more formal human-centered design approach. And frankly, we've taken some lessons from industry, from major companies like Dr. Sharbati works for, where that you start with the end user, understand their needs, and then work backwards to the technology and really, ask what if statements. First of all, understand the patient journey and problems, and then what if this, what if that, and brainstorm, and then try to channel all that into the product development. But then in terms of designing trials, that can look like getting advice from like a community advisory board, like I mentioned, our Center for Health Equity has. It can look like having a patient advisory board that's sort of paid hourly as part of a trial operations. And it could be as deep as having patients full-time on a research team participating in the trial. Maybe I'll turn it over to the other panelists because I'm sure they have more to add.
Yeah, I can I can go a little bit into more of the detail. This is not specific to cardiology, but at least at Google, when products are being designed, the end focus is not necessarily something that the company wants, but it's really focused on the user, right? So everything is focused around something called a critical user journey, where you are kind of marking out the user's goals and the tasks that are going to be accomplished to achieve that goal. So when everything is framed around what the user wants, how the user will achieve, this particular goal of theirs, everything kind of flows from there. And that helps provide clarity for the product team as they're designing the requirements for the engineers. It provides clarity for the usability researchers or, the HCI folks who are going out into the field and doing both qualitative and quantitative work. And it really it provides the overarching themes for product excellence. So I do think there's lots of inspiration that's being translated at institutions like Hopkins and the like, where once the research is framed from a user perspective, it really provides clarity on how to address the focus that really needs it the most, and that's the patient.
I love, Dr. Shavati, the way that you've sort of described that. Essentially, it's very comparable to the approach we've taken at REACH with the design of a maternal mortality prevention program called Happy Mama. And one of the elements of that, which I want to really tie back into some of the comments, particularly that Dr. Mikos had made, is in relation to the data, because we're collecting a variety of data, some of which is, it's bio data, so looking at vital signs and symptoms, but also data that's outside of the traditional data set in healthcare, which is looking at social determinant data and bringing those together. But there's this idea of then leveraging information, data that exists within EHRs as an example, and data that exists across other forms. And we oftentimes tend not to consider that data, and it's a 0 and 1 form, the same way we do when we're, say, taking a biosample, right? We've taken a biosample and using informed consent. We're taking your data that you've given off to someone. Do we really need your consent for that? I'd love to know your thoughts around that from you, as well as some of the others. Dr. Mikos, perhaps if you wanted to kick us off in relation to an appreciation for data being a property and it being something that's owned by the patients, and how do we inform them and have them to participate in designing solutions that are leveraging that data?
Yeah, so this is tricky in terms of, we're really blurring the lines a lot of times between research and clinical practice. And in some ways, and I'm all about getting consent and trying to overcome some of the mistrust and research and being transparent. But in some ways, sometimes these IRB processes and things can then be a burden and actually inhibit progress in research. It can take sometimes so long to go through IRB processes and things that, it slows the pace of research. And especially with things like EHR, if you can de-identify, there's enormous amount of data that could potentially be harnessed and help a lot of patients from what we can learn. And sometimes some of the regulation around accessing that data can be, an impediment. So it's both, it's tricky, both sides. We want to protect patients' data and their privacy and understand how their data is going to be used. But on some hand, overcoming some of these, if it's all, de-identified, from these large data sets and using HR to be able to move research forward at a faster pace. And I think Dr. Lloyd-Jones and others, was talking about things with like EP studies, where electrophysiology studies, where sometimes they're testing a new technique or tech practice, and it's part of clinical care. They're trying to improve their clinical skills and understand what works or not, but then they want to publish about it and show what works and what doesn't. And then that becomes research. And so, how much of this is all has to go through all IRB formal, and how much is actually just innovation in clinical practice, what we do every day. And so these lines get blurred, and I certainly don't have all the solutions, but I think that's one to acknowledge. And then getting back to the other part about health equity, I just wanted to get back to the comment, is it goes back to asking questions that are meaningful to that population. And I've learned so much from working with our Center for Health Equity at Johns Hopkins, led by Dr. Lisa Cooper and Dr. Yvonne Commodore-Mensah has been somebody I've learned a lot for. And the Center for Health Equity, they have a community advisory board, and they get involved really early. Like, it wasn't like the trial's design, can you look at this and, make sure our recruitment's equitable? No, they're involved like before you even design the trial, like asking the questions like, what's really important to this community to study and what will benefit the community. And I think that's how you get at, equity is, making sure that we're asking questions that will directly, meaningfully benefit that population about issues that they care about, which may be somewhat different than what, the researchers think are the meaningful questions.
Very valid point. And it also sort of exposes some of the health literacy needs, right, as well. So why don't we just go to sort of a more, what I consider to be sort of table stakes in terms of creating for better cardiovascular health amongst all communities. And that is to ask this question around health literacy and digital health literacy. I mean, presumably if we ever want to get to the point where we're talking about, good utilization and good outcomes using digital technology and achieving health equity, literacy is so critical. Dr. Shah, would you like to comment on that?
Of course. One of the things I did want to comment on what Erin was saying, though, before we jump into that, I apologize.
Yeah.
We have major databases like the NIS database, which, you have to sign data use agreements. Patients are not consented to be part of this. It's all based on ICD, coding data. I wonder if, when we take our bio data from our devices, if it's de-identified, if we can do something similar with that. And then coming back to your question, Fran, in terms of, using devices and things like that to help improve equity, I do think that, back in the day, we would go into a clinic to get our blood pressure checked. I understand that at these days that, hey, we want this data now. The entire world is now digitized. Why do I have to go into a clinic to go get my blood pressure or my heart rate or my pulse ox? So these sorts of things, I think, is where really the future lies. And I think the community is expecting that medical care catch up to, where everything else is with technology.
Do you think, however, that it's sufficient? Is it sufficient to just say, take your blood pressure? I have to say I have some opinion on that. It's not sufficient, but I'm curious to know, do you think that it is? Do you think it's just enough for a patient to say, well, I could do this at home? What do we believe is missing, and how might we be able to fill that gap so that when they are doing or they do make that choice, it can enable them?
Right. I mean, I talked earlier about the trial that Dr. Blood presented yesterday, where it was a digital remote management program for blood pressure as well as lipids that was driven by Pharmacist, but algorithm driven, and how they all got their digital blood pressure cuffs and were monitoring at home. But they had made like 100,000 calls in that program. I mean, and the question is, it worked. I mean, they doing this remote monitoring. I mean, they had a 10 millimeter reduction in blood pressure, systolic blood pressure. I mean, that is huge. I mean, that can translate to significant stroke reduction. But it wasn't just that they were monitoring their blood pressure at home. No, there was people calling, and there was pharmacists, and they got that blood pressure controlled because they intensified medications, blood pressure medications and lipid lowering medications through algorithms. And so it did still require, it wasn't physician, it was pharmacist led, but it did require a human interaction. And so when you take this to scale, how are health systems, if they want to implement such of a model, how will they cover this? Who covers that expense for the pharmacist to make all those, calls and make all those adjustments? So that kind of remote virtual program works, but it didn't work with just the digital part. It needed someone to facilitate, somebody say, this is the algorithm and this is what we do next. And then I'm going to, write you the medication. And so it needs that other intervention.
Totally agree. Absolutely agree. And I think Dr. Martin, you also came off of mute and had a comment as well.
Thanks, Fran. Yeah, I mean, to build on this, I just wanted to draw everyone's attention to, because this is an HA-funded network, this, especially as we think about blood pressure. So the HERN network, the HA recently funded with $20 million, the HealthEquity Research Network. The name of the total network is now Restore, and the focus is on addressing social determinants to prevent hypertension. Locally at our center, we have a linked BP study, and that's being led by Yvonne Commodore-Mensah, who's closely collaborating with Cheryl Himmelfarb and others. And one of the key reasons I want to bring this up as it relates to this conversation is the role of community health workers. Their team has really built great relationships with our state's community health workforce, and they've done a previous trial, the Rich Life trial, and now through this trial, they're going to bring in more of the technology aspect. And so those community health workers can provide that human touch point around health coaching, but also now to also help with the technology navigation, because again, some people are going to need more or less help. Even if it's the most beautifully designed technology, some people are going to need more or less help. And so this could be an expanded part of the skill set of community health workers to actually provide some of that technology coaching. And that would then ultimately enable, to use it effectively and achieve the outcomes that we're all hoping for.
Dr. Martin, I love that you brought up that example, because it's absolutely where we have seen such tremendous success, leveraging, first off, utilizing community workers and community health educators, because they are local in the community and they're individuals with whom trust has already been established. So that makes it very helpful, and also to help to encourage the continued participation in trials, right, or participation in prevention programs. There are some examples of this are work that were done in India, where ASHA workers, which is the equivalent of a community health worker here, or even promotoras, which are used in the Hispanic communities, have been very, very useful and very helpful in being able to support across a variety of disciplines, and also engaging in the support of their technology needs. So something that I'm glad that you raised, and I'm excited to see that continuing. Pharmacy is another example, right? The role of the pharmacist is one, even in the retail environment, oftentimes is underappreciated in terms of their ability to contribute, to provide for education. We've seen multiple examples in other countries, such as Australia, where they actually are going from behind the counter, if you will, and into the community. And it has had tremendous success. And again, this all being even pre-COVID examples of where we've been able to do a lot more when we're working together with a much more diversified, multidisciplinary team. We had a couple of questions/comments that came into the chat window, one of them of which was asked if we could, do we think that we could do a better job at explaining to our clinical colleagues and to our patients about the guardrails that exist, and that how they can help us make sure that best practices are utilized to optimize patient safety. Anyone care to comment on that at all? Care to comment about safety measures and perhaps the role of researchers, et cetera, in educating clinicians, practitioners, as well as patients? Dr. Shah?
I think the hybrid model, which was also discussed earlier today, is actually a very good sort of bridge to be able to do that. You have your nurses, part of the team, which when you do run a clinical trial, that you rely on and essentially depend on to be able to relay a lot of this information. I think that is a good way to ensure that your patients know that, hey, we do take account of all of these things. We take account of the risks, we take account of the benefits, and we've done a very rigorous sort of IRB sort of approval prior to even being able to present this as a sort of research project.
Mm-hmm. Very good point.
Yeah, I would say I think there's still a lot of work to be done to explain to patients what IRB means. I think even to other clinicians and our clinical staff, what it means, it can feel very much distant and not kind of practical and uplifting and really there to protect the patient. It can feel sometimes just like another hurdle to get through to get the research done. And I think there's a lot of work from, like, as you mentioned, a health literacy perspective to take the language, bring it to a 5th or 6th grade reading level, to incorporate graphics more deliberately, more intentionally, to make it easier actually for our extended workforce, like the pharmacists and the community health workers, to educate and to communicate with patients or trial enrollees. At Google, I spend a lot of time thinking about understandability and accessibility of data, because that's the thing that we're thinking about when we're working with day to day. And we do rely on resources like AHRQ's PMAT, the CDC Clear Communication Index to help guide some of our patient educational materials and our use of visualization and graphics in our UI and our user interface. But I do think that particularly as we rely more upon this extended workforce to help fill in some of our gaps when we do remote patient monitoring or digital health trials at scale, that there's going to be even more onus to make informed consent more understandable for the person who is overseeing the informed consent process. As it gets more distributed, it needs to be even more accessible and understandable for both parties involved, the giving party and the receiving party.
All excellent points. And there are some guidelines as well on how you go about, of course, creating for educational materials, right? And requirements on utilization of graphics, as well as font sizes and recommended language. So I'm really grateful that you pointed that out. And that actually brings me to, I can't believe we're so close to the end of time here. What I always like to have the opportunity to do is to allow our panelists to share a resource or a tool that you've found invaluable. So perhaps I'll go across the screen as I see the names, if you don't mind. So Dr. Shah, we'll start with you. Is there a resource or a tool that you like to recommend or have folks to consider in their practice?
I think AHA has amazing tools on their website in terms of the health technology and in terms of what is available, what they're doing, and what the initiatives are. And I think someone earlier actually posted one of the resources I was going to put. I think AHA has a new, what is it? Let me see if I can just pull it up on the chat. It has a new, new funding opportunity for strategically focused research networks. And I think that is actually an amazing opportunity as well.
Thank you so much for sharing that one. I hope it doesn't sound cheesy or biased, but I would have to say that the work we've been doing with Happy Mama, as an example, it wouldn't be possible without having the credibility of the care plans that are from the American Heart Association being integrated in our platform. We wanted to make sure that no clinician could ever question what the patient is, what they have access to, and that patients felt confident that the content that they were getting was, reliable and credible content. And getting that from the AHA made all the difference, as has our membership into the Center for Health Technology and Information. So thank you for pointing that one out. Dr. Shrivati, would you like to share a resource or a tool?
Sure. I think that the Digital Medicine Society's Playbook is really a great resource, both for entrepreneurs, inspiring entrepreneurs, but also for clinicians who want to better understand how digital products are brought to market. It kind of goes into the details about the regulatory considerations, privacy, from state to state. It's a really rich resource online that is a collaboration across industry. There's startups, including Myocardia, which is no longer a startup, but there's a lot of great information there to kind of understand from the other perspective how we are bringing products to market.
That's an excellent, very valuable tool, and I appreciate you sharing that with everyone. Thank you. We're putting these links, everybody, into the chat window, so make sure you grab those. Dr. Martin, would you like to share a resource or tool?
Yes, thanks, Fran. And first of all, I'd like to just thank you for being an awesome moderator, and to everyone for the great discussion. In terms of a tool, a resource. We recently made this required reading for our MTech Center. So our colleague Lisa Cooper published a book really sharing all of her wisdom from over the years. It's called Why Are Health Disparities Everyone's Problem? So, everyone that's joining us right now, this is all of our problem. We all need to team up and really make the impact that's needed. And so this book, I think, is required reading for all of us. And it looks like you just posted it. Thank you, Fran.
We sure did. And I'm going to pick up my copy. So if you're curious what my weekend plans are for next weekend, you know what it is. Thank you for that. That's a great one. I'm excited to pick up that read. Dr. Mikos, would you like to share a resource?
Sure. It's hard to go last because I agree with everybody else. So, I mentioned a couple studies in my comments. So I mentioned, for example, the Apple Women's Health Study by Dr. Malagingha. So that was recently, at least the design paper was published in the American Journal of Obstetrics and Gynecology in October, just recently last month. And this just is the experience of how they enrolled 10,000 women. And despite requiring an iPhone, was able to enroll pretty representative of the U.S. population. Certainly diversity could be even improved, but they did have a lot more a diverse population than you would maybe think of for a digital health intervention. I also refer to Dr. Blood's study. That was, if you check out the hypertension late breaker clinical presentations, still on demand. That session aired yesterday at 3 p.m. So you can go back and watch that. And then certainly read Dr. Martin and Dr. Marvel's study about the MyCori, their experience with the Cori app after digital intervention of patients after myocardial infarction, because that gets to my last points about the huge resources with the funding from the American Heart Association, who's developed these strategic focus research networks around different topics. And so we're involved in this health technology and innovation. And one of our projects at Hopkins, led by Dr. Martin, is now to take this Cori app really to scale in cardiac rehab and really to scale. But across all the centers, the goal of the SFRNs is to do a collaborative project. And so that we're all working together to move the science forward. So I would check out, the products and the research as this unfolds. And then again, another plug, because I think this is a fantastic mechanism, this SFRNs. I've been involved in 3 prior SFRNs. And so they just posted a new funding mechanism for a strategic focus research network in the science of diversity in clinical trials. So understanding the science behind how we can improve diversity in clinical trials. And they plan to fund 3 center networks and 1 training network that will all be working on this goal. And so the applications are being solicited now for a letter of intent, and then ultimately some who's going to go forward to apply for full application. So these are wonderful funding mechanisms to really try to really move this field forward in a, we know that there's a problem with diversity in clinical trials. Everybody's described this problem, but how do we put rigor and science around what works to move to change this and move this forward for improving access to all?
Excellent, and excellent question being posed. The resources that you have all provided are very valuable, and we appreciate you for providing those. Of course, this particular session will be made available afterwards. I believe there was a question about that. So yes, you will have on-demand access to this presentation. From what you have seen in partial answer to the question that Dr. Mikos posed at the end, the comments that were made here today around, yes, digital technology has the opportunity to not only be an equalizer, but to create for this equity is amazing. And we've cited some tremendous examples that have demonstrated efficacy and effectiveness. So I encourage you to learn more about those. And I'd like to thank everyone for your time today. A great thank you to our panelists, as well as to our audience, and of course, to the American Heart Association, whom without their support, this program would not have been possible. So thank you, everyone.
And thank you, Fran, for an amazing
Thanks so much.
moderator.
Thank you.
Thank you.
Session.
Take care.
Bye.